So now we come on to today's agenda, and we are starting off with our Head of Research, Dr. Julie Greenfield, presenting the latest updates in FA research. And then we'll be joined by Professor Paola Giunti and Dr. Rajith De Silva, both from the London Ataxia Centre, to answer your questions. After these sessions, there will be a chance to connect. And that will give you the opportunity to connect with other people with FA in smaller breakout rooms hosted by one of our volunteers. And that will mean that you will have the opportunity to share your issues or your challenges or things that you've achieved or tips with other people. And that will be open for about an hour after the close of the conference, the close of the FA session. So after the FA session at 2:15, you're welcome to stay with us for the cerebellar ataxia updates, which are looking as if they will be just as exciting as the FA ones, or to log off at this point, in which case we will look forward to seeing you again tomorrow. So without further ado, I'll hand over to Dr. Julie Greenfield to give you the Friedreich's ataxia research update.
Thank you, Sue. Hello, everyone. I'm just going to share my screen so I can start with the slides. Slideshow. Let's start. Lovely. Welcome. So today I'll be giving the Friedreich's ataxia research update. So just to give you a bit of an overview of what I'll be covering, I'm going to start off to tell you a little bit about the activities that Ataxia UK does in research, to sort of show you how we get involved in the different stages of research and the work that we do within the organisation. I'll then move on to talking about the developments in new treatments, and lastly, tell you a little bit about some of the opportunities to take part in research for people who are in the UK. So starting off with the activities that the charity does, there are 4 members of staff within the research department, and I'll tell you a little bit about what we do. So one of the big things that the charity has always done is fund research. So we have a research funded programme where we invite researchers from all over the world to submit grant applications, and we have a very rigorous system to evaluate which research we then fund, with thanks to the fundraising efforts of many of you who help by donating to Ataxia UK. And we monitor how the research does, the research that we fund, and every year we publish an impact report. And with the latest one, the 2023 one, we looked at a number of different things, but one of the things we do look at is funding. And what we find is that for every £1 that Ataxia UK spent on research projects, raised another £5 in further funding for ataxia research. So you can see it's a really good return. And what that means is that actually the researchers we're funding are succeeding in carrying on in working on ataxia research and in getting funding, mostly from other funding bodies. So it's a great way of seeing the progress that the research is doing. And we also evaluate a number of other things, such as publications and engagement activities. So that's our funding programme. Another big thing we do is we do research events. And our big sort of flagship event is the International Congress for Ataxia Research. We've been working jointly with FARA and NAF, the 2 US charities, in running these conferences. The last one was in 2022 in the States. And this year, we're actually holding it in London this November. So as you can imagine, we're extremely busy with all the organisation of this event, and it's really promising to be an excellent one. And we've got a huge amount of interest from researchers wanting to attend. So we're thinking that it's going to be the biggest research event for the ataxias ever. So we're really excited about that. And we're working, as I said, jointly with the FARA NAF and also with the Ataxia Global Initiative. Last year, we also had a smaller event just for UK researchers, because we wanted to sort of encourage networking and collaboration between people there. And that's a photo of the event there. There were about 50 researchers, and it was really welcomed as well. So in terms of other activities that we do, so Ataxia UK is a link between researchers and the ataxia community yourselves. So we can facilitate the recruitment to studies, be these trials or surveys. We want to make sure that we're engaged in ataxia research, and we ensure that the patient voice really is heard and is very much part of the research process. And so we work with academic researchers, but also with pharma and biotech companies. And in terms of working with companies, one of the big things we want to do is encourage involvement in ataxia research. So, for example, by holding these conferences, we encourage newcomers to the field to come and learn from the different ataxia researchers. And also we are able to provide much information because we sort of know a lot about the landscape in ataxia. And we assist in the drug development programs of the different companies. We have regular meetings with many of them and help with the collection of useful information. So, for example, as you may be aware, that we quite often send out for surveys and workshops and people to come forward to be taking part in advisory board meetings. And all these things are important to make sure that what is important to people with free drugs ataxia and their families is being considered as part of research and as part of the drug development process. So this is the sort of number of things that we're involved in at every stage of ataxia research. So then I thought I'd just go over very briefly, before I start talking about the developments, what the process of clinical trials is, just to sort of put everything into perspective. I'm sure many of you know this already, but I just felt like it would be useful to put things in perspective. So the first steps, of course, are for researchers to come up with hypotheses, with ideas of what drugs or treatment could potentially be of benefit to free drugs ataxia or to any condition. And then they would test them in preclinical studies, where a drug might be tested in models, such as cell models or animal models, to see whether it's effective, to see what doses might be used before you actually move on to human studies. And cell models, for example, could be things like induced pluripotent stem cells. And these are, for example, cells that could be taken from the skin and reprogrammed in the laboratory to become like nerve cells. So you're really looking at the effect of drugs on nerve cells or animal models. The next step, once you've sort of done all that preparatory work, once you know that the drug is safe, at least in animal studies, you can move on to testing it in humans. And that can be either in people without the condition or in people with free drugs ataxia. And this is very important in terms of seeing the safety of the drug and also how the body processes the drug and getting information on the doses that you may then want to use in a larger trial. So then you move on to phase 2 trials, which can take several months or a year or two. And there you're looking at the potential risks and the benefits of the drug may have. Does the drug actually work in people with free drugs ataxia? And carry on finding out more about the safety. And lastly, phase 3 trials are where you're often looking at a placebo-controlled trial and the effect in the people with the condition compared to placebo. And once again, you're also looking at the safety, etc. And in rare diseases, although this is very simple schematic sort of representation, in rare diseases such as ataxia, you often get some of these phases combined into one. And it might have some differences because of being a rare condition. Now, once all this has happened, once you've done the trials, the next steps are the regulatory steps. So firstly, a treatment needs to get a license from a regulatory agency before it can actually be made available. And in the UK, this is the MHRA, and in Europe, it's called the EMA, the European Medicine Agency, and in the US, it's the FDA, the Food and Drug Administration. So this is an important step that needs to then happen. And then the next step, step 2, is you need to make sure that it gets reimbursed. So in the UK, there are different bodies that decide whether the NHS will provide the treatment. And in England, Wales and Northern Ireland, that is called, the body is called NICE, the National Institute of Clinical Excellence, and in Scotland, it's the SMC. So these are important steps that need to happen so that the drug would hopefully be approved and available on the NHS for people to access it. So this is sort of, as I said, a little bit of a preamble and an explanation. I'll now start talking about some of the developments in the treatments. So in terms of how, in what is important in FA research, many of you will be familiar with the causes of Friedreich's ataxia. So you get a mistake in the frataxin gene, and what the mistake is an expansion in the GAA repeats, which are part of the building blocks of the DNA. This leads to a reduction in the amount of frataxin protein that is produced, and frataxin has many important functions in the cell. So when you get a reduction in this frataxin, you get a number of processes that are disrupted, and you get oxidative stress, which causes damage to cells, an increase in iron in the mitochondria, which is the part of the cell which is responsible for production of energy. You get cell damage, you get disruption in mitochondrial function, and a decrease in energy production. And these pop-up things that are popping up a bit faster than I was talking show how we address some of these issues. Oh, God, sorry. Not quite sure why it's gone to the next slide. Oh, sorry, I'll just have to stop that a second. Go back to here. Current slide. Right, so I've gone through this, apologies for that. So you can target the mistake in the frataxin gene by using genetic approaches, such as gene therapy, ways in which you could correct and replace the frataxin gene. Or you can target here the reduction in frataxin protein by increasing the amount of frataxin protein. Or you can target this point here of the disruption processes by targeting with different drugs can affect that point. And in the next few slides, I'll show you some of the treatment developments that are using approaches that are targeting this step, or that step. So, genetic approaches in Friedreich's ataxia. So there are a number of genetic approaches that are being adopted by a number of different groups around the world. One company that's using a genetic approach is called Design Therapeutics, and they have designed a sort of drug that targets the mutation in the frataxin gene. And in 2022 and 2023, they showed results from phase 1 clinical trials that showed promising initial results. They then conducted some non-clinical studies, meaning studies in animals, to improve the formulation of this drug. And in March 24, the new formulation showed improved absorption and safety. And the next phase of trials are expected next year. So that's one company. The next company is one called Lexeo Therapeutics that have designed another type of gene therapy approach. Oh my God, sorry, I don't know why that's skipping on to the next slide again. I'm wondering if I use it like this, it might be better. Otherwise, it might keep skipping. So, Lexeo Therapeutics have a phase 1/2 clinical trial called Sunrise FA, where they've got 3 increasing dose cohorts. And last year, they found that the first cohort tolerated the dose well. Then in March, they looked at the second cohort, and not only was the dose of the drug tolerated well, but they also found increase in the frataxin after 3 months, only 3 months, which is of course very encouraging because that's what we want to see. And then in July, they showed some interim data showing some clinically meaningful improvements across some of the cardiac markers. So some of because they're targeting the heart specifically, which of course is important in Friedreich's ataxia. So this is really quite exciting research if you think about it. You know, we've been talking about gene therapy approaches for many years. To have got to the point where these are now being tested in people with Friedreich's ataxia, it is really, really encouraging. And then I wanted to move on to some other approaches. I mean, there's actually quite a few research groups around the world that are conducting preclinical research for gene therapies. And here are some examples. So there was some updates recently from Prime Medicine, where they're using a gene editing approach, targeting these GAA repeats, and they showed some promising preclinical results. There's another company called Voyager Therapeutics and Neuroendocrine Biosciences that have got a gene therapy replacement drug that they're hoping to start trials next year. There's also another company called Astellas that is doing a gene therapy approach. So there's a lot of interest around the world with these genetic approaches in Friedreich's ataxia. So these are the genetic approaches. Moving on from the genetic approaches, I wanted to talk about the approaches. Here we go, that's better. Looking at increasing this reduced frataxin protein. So an approach where you're actually increasing levels of the protein. Sorry. And here we have a company called Larimar Therapeutics that have a protein replacement therapy. So they developed a drug that actually delivers frataxin to where it's needed within the cells. So within these mitochondria, which are these compartments of the cells that are important in, which is where frataxin is found. And this research has actually gone on for many years, and we've been following it with great interest. And it's really wonderful to see that now they're at the clinical trial stage. So they had a phase 2 ascending dose trial, so looking at what dose would be needed. And in February this year, they showed some positive top-line results where they showed that this protein replacement is well tolerated in both doses that they tested, and it also increases these frataxin levels after just 14 days, which is of course very important, which is what we're looking to do. And the open label trial is ongoing, and they're expecting results at the end of the year. Now, the next sort of group of therapies are looking at these disruption of the processes. So you're not looking at the gene, not looking at the frataxin protein, but the downstream effects of reduction in this protein. And some of these processes, such as oxidative stress and cell damage and the mitochondria, which is disrupted in their function and less energy produced. So there's many different groups looking at different drugs that target this in Friedreich's ataxia. And of course, as all of you know, one of the main drugs that's come out is omaveloxolone, and this is one that targets this mitochondrial function. Now, omaveloxolone, the brand name is also known as Skyclarys, so I'm sure everybody's heard of it. It was originally developed by the company called Reata Pharmaceuticals, but in September 2023, it was acquired by the company Biogen, and it is the first approved drug for FA. It was shown to slow progression of the condition, and as I'm sure you're all aware, the FDA in the US, the regulators in the US, approved a drug for use in adults aged 16 and over in February 2023. And this was then followed by approval by the European Medicine Agency in February 2024, so that people in European countries have an approved drug. Now, for the UK, there are, as I mentioned earlier, the regulatory process consists of two stages. The first is the MHRA, which needs to approve the drug. And secondly, you have NICE or SMC in Scotland, who decide whether the drug will be available on the NHS. Now, in July this year, we were able to announce a bit more information on the timeline. So Biogen intends to submit to the MHRA this year, at the end of this year. And so we anticipate that the outcome of that will be known around April or June. So hopefully, if all goes well, there will be a license for the drug in April or June. And then Biogen are also working on the evidence submission to NICE. So the NICE process is such that the sort of first step involved a scoping stage. And there was, in fact, a scoping workshop at the end of August that Ataxia UK also attended. So as part of the process, the company has to submit information to NICE. However, there's opportunity for other stakeholders, such as Ataxia UK, to provide evidence. So we provided some written evidence, and we attended the workshop and sort of tried to explain about the impact of FA and look at the different questions that they were asking and trying to sort of influence the system, not the system, impress the process for the benefit of people with FA. So as part of this, we actually are asking people with FA to come forward to help us. So one of the things that's needed is some case studies of the impact of Friedreich's ataxia. Now, we obviously have a lot of information from people with Friedreich's that we've collected over the years, but if anybody is willing to share their stories and the impact the condition has on them, we would really love to hear from you. And we'll be putting out communications in our newsletters about this as well. And secondly, if anybody is actually taking omaveloxolone, which in the UK, I imagine would be people who actually were on the trial, the small number of people who are on the trial, we're also interested in hearing the feedback on the effect that the drug has on you. And that can also be fed into this nice evaluation process. So please do email us if you're willing to help us with this, with these things. Now, just to sort of explain a little bit going backwards, what does the omaveloxolone do? So as we know, as I explained earlier, in FA, you get reduced frataxin, which leads to this oxidative stress, disruption in the function of mitochondria, and less energy produced. And the omaveloxolone acts on that. So what it actually is, it's what's known as an NRF2 transcription factor activated. And what's been found is that this sort of effect of this drug is to increase mitochondrial function and increase the amount of energy produced in cells. So it's actually a disease-modifying treatment for Friedreich's ataxia. It's targeting some of the things that go wrong in the cells of people with Friedreich's ataxia and trying to correct them. So that's sort of a really nice thing about the drug, that it's looking at being disease-modifying. So as people will be familiar, there was a trial which led to then the eventual approval by the regulators. And the trial also was a global trial, but it also did include the London Ataxia Centre. So Professor Giunti led the trial site in the UK. So there were first parties looking at safety. And just to give you a feel for numbers, there were 69 people in the first trial. And that was, results came out in 2018. Then the second trial was a larger number of people, results in 2019. The third open label extension, where everybody was on the trial, 92 participants, once again, results a little bit later. And then the last part, which was also the part that was needed by the regulators on top of these sort of placebo-controlled trials, was also a comparison of people who'd been on the drug in the trial with data from people who'd been on long-term natural history studies. And they showed that the progression was slowed in the people who were on the drug compared to the data from people on these long-term natural history studies, which really very much shows the importance of these long-term natural history studies, which have been going on, in fact, and I will talk a little bit more about them now, but later on. But one of the ones that people will be familiar with is one called EFAX, which has European sites, and the UK is included in that. And it shows how this sort of background research that might not be testing a drug, but is actually very much needed for the drug development process. So that is all for omaveloxolone in adults. So how about in children? So they need to do trials to see if omaveloxolone is safe for children under the age of 16, because at the moment it's only for people aged 16 and over. So there is currently a phase 1 study in the States, with one site in the States, that started this summer. And it's assessing the safety and tolerability and looking at the dosing as well. And it's quite a small trial with 20 participants, and the age range is between 2 and 15. And they're looking at, as I said, the dosing. And then this will be followed by an open label extensions where people on the trial will carry on taking it, and then with a global pediatric trial with a number of sites around the world. So that is all about omaveloxolone. So of course, it's really exciting that we've got to the point where there is a drug approved, not approved in the UK yet, but at least it's approved somewhere in the world. So that is really exciting. But there's a lot of other research ongoing as well that might lead to other drugs being approved. So the next one I wanted to talk about was vatiquinone, which is a drug developed by PTC Therapeutics. And this is once again something that targets the oxidative stress and some of the sort of damage to the mitochondria, a bit like, I mean, in a different way to rivaroxaban, but it's targeting those kinds of things. It's not looking at the gene itself. So in May 23, there were results published of their trial, where unfortunately there was no significant change in the mFARS score, which is a rating scale used in Friedreich's ataxia trials. However, they did see meaningful clinical benefit in a couple of things, one being upright stability, so the ability to stand and walk, and the other one being speech and swallowing. And this was measured in 146 adults and children at 72 weeks. So this is something that they're looking at adults and children at the same time, in fact, interestingly. So the next steps, the company PTC have discussed with the European regulators if the data could be used to apply for approval, and they expect to hear back this year. In February 2024, following a meeting with the US regulators, PTC plan to submit a new drug application also in the US. And they're also exploring the need for additional trial based on the feedback from the regulators. So sometimes regulators will say, this is just not enough evidence. You need to go and do another trial, gather more evidence before we will consider it. So they're at this stage. So although you know, they haven't got a drug approval, it's kind of at the regulatory stage. So promising. So lastly, I want to touch a little bit about opportunities to take part in research. So I've given very much of a sort of quick overview of the interesting lines of research in Friedreich's ataxia, although there are others that I haven't touched on. So for example, there are a number of other drugs that are being investigated that fall into that category of reducing oxidative stress and damage to cells. So for example, there's a drug by the company Minorix Therapeutics, or there's the drug dimethyl fumarate, where there's a trial ongoing. There's the drug elamipridine, which is by the company Stealth Therapeutics, which has also got a trial ongoing. So there are a number of other things. I obviously didn't mention everything. There's a lot of research interest in Friedreich's ataxia around the world. So talking about opportunities to take part in research in the UK. So the natural history studies, as I mentioned, really important to gather this information, and the EFACS natural history study has been ongoing for a long time, and it involves people with Friedreich's ataxia attending the clinic in London once a year, and they would gather information on ataxia rating scales and maybe blood samples and a number of different things that will be measured. And that is being very important for use in the trials from both drug companies and academic trials. And as we said, it's important data. It was also included in the approval of rivaroxaban. Then there's another trial taking place where they're using wearable technology to investigate the impact of FA on balance and gait, and understanding a bit more the balance and gait features of people with Friedreich's ataxia. Now, the FA Global Clinical Consortium is an effort to combine the natural history studies in different parts of the world and put them in one common database. So EFACS will be incorporated in this. The American sites will incorporate it. So the plan is to have 33 clinical sites in 18 countries. And this is something that is taking place at the moment, this sort of combination of different natural history studies. And then there's the FA Global Patient Registry, where people with ataxia actually input the information themselves on an annual basis. There's the FA app, which is once again something else that people can include information about themselves. It also aims to connect people with FA, and this is being run by a charity called End FA. So we're always happy to publicise initiatives of other organisations. There's a project called Project Euphonia, which is where they aim to record speech samples from people with different conditions, and it's open to people with Friedreich's ataxia as well. And the idea is that it will help to sort of improve voice recognition software. And this is part of the Google's AI Social Good program. And then there's a number of studies on the impact of speech therapy which are delivered online. And all these sort of opportunities to take part in research are always featured on our website. There's a section specifically called Taking Part in Research. And so I would urge you to sort of have a look, and we also sort of publicise things regularly in a magazine and e-newsletter whenever there's opportunities to take part in research. So thank you very much. I will stop sharing my screen, and I am very sorry about the technical issues there, that the technology obviously wanted me to talk faster than I could talk. So sorry that I had to go back to that different version of PowerPoint. But hopefully that doesn't disrupt things too much. So I'm happy to take questions. Now, what we thought is that as we also have the doctor's Q&A session with Paola Giunti and Rajith De Silva, I was just looking to see if they are in the room.
Paola's with us.
Thank you. I thought that we could introduce Professor Paola Giunti and Dr. Rajith De Silva and then start the question sessions. And if you've got any questions for me, we could start with those, but they might want to join in the answering of those questions as well. So, Paola, are you there? Okay, maybe we'll wait for both of them to be here and I can then introduce them. So if there's any questions for me on the research side of things, I'd be happy to take them now. I can see that Rajith is here as well now. And then we will move on to, oh, hello, Janet, did you want to ask a question? I think you're muted. Still muted.
Janet, you need to touch the microphone button, which should be on the bottom left of your screen, because we can't hear you at all. And my lip reading is needing... Oh, there you are, you're there. You're there, you're with us. Speak your question, please.
Thank you, yes. This research to do with Friedreich's ataxia and the new drugs which are being tested, are any of them likely to help with cerebellar ataxia?
Some of them might. Obviously not the gene therapy research, because they are very specific to the frataxin gene. But some of the more generic drugs, I mean, omaveloxolone potentially could be something that could help other ataxias. It's something that would need to be explored and researched in detail, but some of these drugs would have potential, so, because some of them have more generic things like antioxidant effects, and actually oxidative stress does happen in other ataxias as well. So yes, I think potentially some of these drugs could lead to benefits in other ataxias as well, but they would need to be tested and trialed. Also, the other thing is, of course, as soon as you get one drug approved, the regulators get used to ataxia as a condition, and get to start accepting some of the rating scales that are being used. So I think all that helps in the future of the approvals for other drugs as well. So there's a sort of number of different things that will improve as more and more drugs get approved. So yes, I think some of them would be relevant and could be potentially of benefit to other ataxias.
Okay, thank you. And there is something else while I've got you there. Why do you think my GP said that ataxia is not an actual disease?
Now I think I will now introduce the neurologists, and maybe that is a question more for them to answer. and we can then carry on with the questions. So I would like to welcome Dr. Rajith De Silva, who is here with us. He is a consultant neurologist at Queen's Hospital in Romford and also works at the London Ataxia Centre. And then we also have Professor Paola Giunti, who's the head of the London Ataxia Centre, who I think is just, I can see that she's there, but I can't actually see the video, but maybe that's not working.
Julie, by way of explanation, I think Paula's having some technical difficulties getting herself heard. She can hear us, and she obviously can see, but I gather she's trying to get some technical support to enable her to speak to us, as it were.
Lovely. I can see that it seems to be working now, actually. So perfect.
So shall I perhaps have a stab at trying to answer Janet's question, which is both her points are excellent, really. So the term ataxia is used interchangeably I think. In a sense, your GP is correct, because ataxia is a symptom. It refers to the incoordination and the clumsiness and the unsteadiness that folks with ataxia have. But in itself, it's not a diagnosis, and we know that conditions as diverse as, strokes, multiple sclerosis, tumors in the brain, hydrocephalus, all of these conditions can cause ataxia as a clinical symptom and sign. However, in this kind of setting, we are honing in on slightly more specific causes of ataxia, like Friedreich's ataxia. So I think, as I say, I think it's probably terminology rather than sort of, and I think that's possibly, but it's not entirely correct to say it's not a disease, because as you guys all know, we use it to describe particular forms of causes of ataxia, such as the dominant ataxias with all the associated different genes, and also Friedreich's ataxia and some of the recessive ataxias as well. Can I just go back to your...
Sorry, can you hear me?
Yeah, we can, Paula, now. Yeah.
Perfect, thank you. Sorry, apologies.
I I entirely endorse Julie's point about the fact that some of these drugs, although they're in the initial phase and they may receive approval for Friedreich's ataxia, it may well be that they have effects outside of that confine, and I agree with her that given the fact that this is probably an antioxidant that reduces oxidative stress on cerebellar cells, it may well have some and that really is a really interesting point. I think at the end of the day, and we were at another meeting earlier on this week, if you were to sort of project forward, say 100 years from now, it may well be that we have cocktails of therapies becoming available for patients with ataxia. So there may be very targeted treatments going for the particular gene that is implicated, but then there may be different levels where there are more supportive therapies. And I suppose at the widest range, even some of the not in this context, we're not talking about drug-based treatments, but treatments like physiotherapy and so on, they have applicability across the board. So it may well be that there's a gradation of treatments from highly specific ones for particular disease entities to more broad-based approaches, drug and therapy-based, which cover the entirety of the group as well.
Thank you. Thanks, Rajith. So, Paola, did you want to add something, or should we?
Yeah, sure. Indeed, ataxia is an umbrella term. So it means lack of coordination, and so many different causes can produce ataxias. However, for among neurologists, it is very well accepted that when we're talking about ataxia as a condition, we have in mind quite a specific number of causes, and among which is a neurodegenerative disorder like the Friedreich or the spinocerebellar ataxias. So for the GP point of view, I can well understand that he will say, well, ataxia is just a descriptive term to indicate the lack of balance. It doesn't indicate the cause. However, there is as well among neurologists, when we are talking about ataxia, we have in mind as well very quite specific numbers of cause.
Lovely. So I can see that there's a question on the chat where somebody is saying, I was wondering if there's any possibility of joining the Larimar Therapeutics trial for FA if in the UK. So at the moment, the Larimar Therapeutics trial is not in the UK, it's in the States. I mean, we always try and encourage companies to come to the UK, and we would let people know via our normal communication channels if there is a trial and opportunity to take part in the UK. But at the moment, I'm not aware that is the case. I don't know if either of you have any other information on that, but I don't think.
Yes, so I know that Larimar is looking for as well a site outside the US, but I don't think that anything has been decided yet.
Yeah, yeah. But
and in general, I would add that everyone in theory, in principle, can participate on the clinical trials. However, then it is up to the then pharmaceutical company that will draw the clinical trial design, then indicate the inclusion and the exclusion criteria. So there are some trials in which they are quite flexible, and for example, for age. So characteristically, as Julie has said, we distinguish before anything else the age. So the adults towards the pediatric trials. But among the adults, there are some that are more restricted in age, and more that they are more flexible, so they are more comprehensive. So this is depending, I'm afraid, on, and the decision is down to the pharmaceutical company and that are establishing the clinical trial design.
Yes, yes. So of course, we'll always publicise the trials that are available, but as Paola explains, even if the trial is in the UK, it doesn't mean that everybody necessarily can take part. And some of the trials are also very small numbers of participants, aren't they? So especially in the first stages. But anyway, definitely when there are opportunities, we will let people know. So there's another question here on the chat saying, I'm confused how ataxia is often inherited, but is a symptom of other diseases. So I think that's probably an expansion of what you were just talking about earlier, Rajith, in terms of ataxia being a symptom rather than a condition per se. I don't know if you want to sort of talk a little bit more about that.
So if it helps, it's really worth drilling down as to why ataxia arises. And so there are various structures in the nervous system that are involved in helping folks to maintain coordination and balance. And primary, the most important of these, I guess, is the cerebellum, which is a structure which is attached to the back part of the brain. But there are also connections to the cerebellum. So there's a sensory system that feeds into it, and then there's a so-called a motor system that also influences it. And we know that if you get problems with the sensation or sometimes the power, the input into the cerebellum, you can get problems as well. But primarily, when we think about cerebellar disorders or ataxic conditions, we are talking about disorders of the cerebellum. So if you, therefore, if you have some form of disorder affecting the cerebellum, and this can be a structural problem like a tumor, or if there is inflammation within the cerebellum, or indeed if you get a stroke, blood supply disruption to the cerebellum, you can get ataxia, of course. But when Paolo was talking about neurodegenerative conditions, and that's where the genetics come in, because on the whole, these conditions tend to be determined by abnormalities of the gene function. And it's really intriguing why some genes purely cause disorders of the cerebellum, some have implications outside of the cerebellum, but there are, of course, other genetic disorders which have little or no influence on the cerebellum. And that's to do with how genes are expressed in different parts of the nervous system. But the point of commonality when we talk about ataxia is that either through a genetic defect affecting the cells of the cerebellum, or a structural abnormality, or a problem with the blood supply, or whatever, the disorder results in damage to the cerebellum. So that's the linking point. I hope that helps you to understand why a proportion of cases have a genetic basis, in other words, have a hereditary component, whereas another group, in fact, probably the vast majority, actually, although they don't come into an ataxia UK sort of group, will probably have other causes to cause their unsteadiness. I hope that's clear.
And
Yes,
also,
thank you.
if you go to the Ataxia UK website, there's a leaflet called What is Ataxia? And that tries to explain things very simply, so that might be helpful as well. So thank you, that's great. So we did have a question that was sent in advance. I think maybe we could go to that question. And that is somebody who's a parent of somebody with Friedreich's was saying, I understand that's been research into whether any of the medications approved for other conditions could help people with FA, which is something we've already touched on. And then they were asking specifically about DMF, which is dimethyl fumarate. And sort of saying if Ataxia UK was seeking approval for this, and any others that have been found to be used in the treatment of FA, and how long will this approval take to be granted. So I don't know if you would maybe want to comment on the particular case of dimethyl fumarate and in general on that. Obviously, so in terms of approval, I mean, it's not Ataxia UK that does the seeking of the drug approval, but I think the what you mean by the question is how is that particular trial progressing, and the effect of treatments from other ataxias on FA.
Yeah, so I can comment on that. So the DMF is very interesting drug for us, because it has the same pathways and uses the same pathways of the omavoxalone. So it's an NRF2 activators, and it seems to be working as well on the FA. We have done preclinical studies on cells for patients with FA, and then there is one trial that is going on in Naples in Italy, and so we will very much interested in seeing the results, because obviously one thing, as Julie has explained before quite very, very clearly, one thing is to find a results and a response on cells or mice, and one thing is then having as well the drug showing that is efficacious, that is working in patients. Not only that, because there is as well one other very, very important element to understand, and it is about toxicity. So the DMF has been as well proven not with serious adverse event, and so we need to be cautious. Obviously, in another pathology, not in Friedreich, as far as I know. So far, the trial is proceeding fine, but it would be very important to see the end of the trials and the results.
Yeah.
Julie, if I may add, yeah, so there's sort of repurposing of drugs, isn't it? Drugs that are not primarily. So Julie gave a very nice introduction in terms of, how you could target the frataxin gene itself and so on, and then you move further out as we were discussing. And I think these are, interesting observations. But I think, as Paola has emphasized, I think one has always got to be aware of potential toxicity and the weighing up of the potential benefit against the risk to the individual. We have some. I mean, I suppose on the plus side, because this drug has been used in conditions like MS and in I think in psoriasis as well. There is some experience, and just to give you folks just a why it is such a tricky situation is that there's been a very serious, in a very small number of patients, admittedly, just over about I think about 11 cases, a very serious neurodegenerative condition. It's a virus, what's called a slow virus, has affected because of the immune suppression that accompanies the use of DMF. They have been associated with a very, and almost always is a fatal brain infection called progressive multifocal leukoencephalopathy. Now, admittedly, the number is very small, but nevertheless, it emphasizes the fact that one has to proceed with extreme caution. On the, there's a huge temptation when you're faced with a disease as serious as Friedreich's ataxia that you would clutch at lots of straws and try to do, but you've also got to be restrained by the fact that potentially these drugs are very, very serious. And one of the great dangers, as we as physicians, Paola and I, and the other ataxia specialists, we're always very conscious of is we shouldn't expose our patients to additional risk with potentially little or no benefit at the end of it. So we do need to study these drugs in more detail. We need to have better quality data and then make an informed decision with your corporation as to whether or not it's a drug that's worth using in a condition like Friedreich's.
Thank you. So I can see that there's another question in the chat. Do you know anything about the trial conducted in Bristol by Dr. Wilson for GCSF injections? So that was a trial using a drug that's once again a repurposed drug. So it's a drug that's available for other indications that was being tested in Friedreich's ataxia. And there was some preclinical studies, and then there was a small pilot study in people with Friedreich's ataxia. And the team at Bristol had always planned to do a follow-up larger trial. I did talk to them a lot in the early stages, and I think they were planning one, but unfortunately nothing's happened yet. Dr. Wilson is no longer at Bristol, so he's moved to a different place. And I think there was a clinician there in Bristol who was keen to take a trial forward, but unfortunately there hasn't been any progress at the moment, so there isn't a trial yet. Yeah, unfortunately nothing to report there. The next question is, could inflammation cause atrophy of the cerebellum?
So let me just give a very broad, so there are different forms of inflammation. One of the ones that is quite interesting is after chickenpox, usually children can get swelling, especially of the cerebellum. It's a condition called cerebellitis. But then I think we were talking earlier about slightly more common disorders in a slightly older population, adults, young adults, and older, which is multiple sclerosis, where the inflammation tends to be more localized. But in general terms, your point is well taken. As the swelling subsides, depending on the severity of it, you can end up with some sort of reduction of the brain, the cerebellar volume, the size of the cerebellum. Luckily, particularly in the kids, in the case of the acute cerebralitis after chickenpox, it doesn't tend to be very marked. So they may make a complete recovery. However, for example, in slightly more chronic forms of inflammation, like in MS, you can end up with some permanent injury and some more sort of permanent cerebellar injury, although there it tends to be slightly more localized than affecting the, but in general, depending on the severity and the length of time over which the inflammation takes place, yes, because cell death can occur and you may end up with, but it's a little unpredictable, depends on the severity of the infection, the duration, and I suspect, I don't know any, Paula, you might know better, is it related to age as well? Because we know that there's a greater degree of plasticity and recovery in certain populations in relation to the cerebellar in their response to injury.
Yeah, so one thing that needs to be said, that inflammation can cause atrophy, can cause shrinkage of the cerebellum. However, what is usually distinct from other processes like the neurodegeneration is that if you have a cerebellitis, so it's an inflammation of the whole cerebellum, once that the event with the virus or other causes, it's finished, then you do not have anymore the progression of the disease. So you do not get worse. You just stay, and there is the level of ataxia that has been produced by the inflammation of the cerebellum do not start to get worse and or to shrink. So it is very, very important on the clinical point of view to understand, because one can have a it is very rare, but it can occur, and it did occur in some of my patients, that they actually have had this cerebellitis, the inflammation of the cerebellum, and then after one period of plateau, they started to deteriorate. And then we have request the genetic test, and this person was as well positive for a genetic form of the cerebellar ataxia. So it is complicated, but it is really important to distinguish the two. And for the practical point of view, if something is progressing, we need really to investigate and need to go back to the doctor if you feel that things are getting worse. Certainly it is worth to investigate and start the investigation again from scratch. That is something that's a practical advice that I can be able to share with you today, because it's important.
I love these meetings because you guys ask all the really intriguing and interesting questions, and I've had a couple of thoughts just reflect and listening to what Paolo was saying as well, because the reverse can happen as well. Of course, you can have a genetic ataxia which is slowly progressing over a number of years perhaps, and then there's a sort of sudden decline. And again, I entirely endorse what Paula is saying. If that happens, you must seek advice, because there may be something reversible that's superimposed on your ataxia which needs to be addressed, and sometimes quite urgently. The other point, we are now straying way beyond Friedrich's, is that there's you guys are probably aware of this entity called autoimmune cell. It's called primary PACI, isn't it? Primary autoimmune cerebellar ataxia, PACA. Yeah. So this is immune induced cerebellar ataxia. So we are trying to learn more about it. It's a slightly a nebulous concept. We know that there are some specific situations, for example, in patients with underlying cancer, for example, you can have what's called a remote effect. So in response to the, like an immune response to the cancer can induce a form of inflammation. It can affect any part of the nervous system, but we know a characteristic form affects the cerebellum. And then you also, at these meetings, you probably heard about gluten ataxia, which is another form of immune mediated cerebellar injury. But then there's a third group where the etiology or the basis of it is unknown. So that's another key area of active research, where people are thinking about immune induced and inflammation derived cerebellar injury. What is really interesting in those groups is in this area is that people are trying to tease out to try and identify, if you like, a stage before the damage has occurred, because there may be a window of opportunity where, with the use of immune-based therapies, we can try and reverse that inflammation and stop the injury from taking place. So that again is a space to watch, and people like Professor Hadjivasiliou are quite involved and interested in looking at that, particularly tackling that window of opportunity to try and stop cerebellar injury permanently.
Lovely, thank you. Are there any other questions that are specifically on free drugs? Oh, here we go, we get one in the chat. If Skyclarys is approved and distributed, being a rare disease, would the pool of trial candidates on other trials be reduced, or would trial candidates simply stop taking Skyclarys? So that's a question about future clinical trials, I suppose, a very good question about future clinical trials and what would happen.
So this is pretty much depending again on the new trial. So there are pharmaceutical companies that for the composition of and the pharmacological characteristic of the new compound, the new drug that they are trial, they will ask to stop the omaveloxolone or others that are completely different, and then they could easily accept that you continue to take omaveloxolone. So it's really depending on the pharmaceutical company, the decision they want to take about their trial new drug. And it's very much case by case. There is no universal rule, but it's depending pretty much on the mode of action of the new molecules, and if they, in their view, allowing patients to stay on an RF2 activator, another drug, and this it was pretty much the case with many other trials that were patients, for example, they were taking CoQ10, and therefore patients were asked to stop the CoQ10 and others not. Or it is possible that at the beginning, when they are doing a double blind placebo trials, they were not allowed to stay. And then when they are in an extension phase where everyone is taking the trial drug, the study drugs, then they become more, the rules become more flexible. So it's really case by case. It's very difficult to predict.
Yeah. And I suppose, although in Friedreich's ataxia, it's a relatively new thing, although, as you mentioned, CoQ10, but Skyclarys being the first approved drug, it's quite a new thing, but there must be a lot of experience in other conditions where there are already other approved drugs and how are trials managed in those cases. So there'll be a lot of experience out there as to how it's done, whether, as you say, people are allowed to take it, and then you have...
Yeah.
Yeah.
Yeah, one is very much lots of experience is in cancer. This is the most experience of all, in which they were allowing other treatment which the patients were on, and adding in an additional treatment that were trial. So, but it's depends on case by case on exactly the mode of action of the drug that is going to be trialed.
Lovely, thank you. So I can't see any more questions in the chat. I don't know if anybody has any other questions on Friedreich's, otherwise we can close this session and move on to cerebellar ataxia. I don't see any hands.
Douglas Ross.
Sorry, Sue, did you?
No, that's not me speaking. I think that's somebody from the background. But before we move on to the cerebellar ataxia sessions, let me first explain to you what's going to happen next. So we are going to move to a session, all you Friedreich's ataxia people, we're going to move to a session called Chance to Connect. And those of you who have Friedreich's will be offered the opportunity to join a small discussion group, which will be facilitated by one of our volunteers. And they will, and you can join that, and the room will be open for an hour, where you can just chat to a few people who are in the same situation as you and have a connection to Friedreich's ataxia. Now, we know that there are people in this room, in this meeting, that want to be here for the cerebellar ataxia session. And if mistakenly you get assigned to one of these breakout groups, just press leave when it offers you the opportunity, leave the room, and you will be sent back here. And if by any chance you get knocked out of the meeting, then just rejoin using the link that you used originally. Before we start the FA sessions, the Chance to Connect sessions, we'll have a quick look at the programme for tomorrow. And tomorrow morning, can't quite, there we are. So tomorrow morning, we will have an update from me after a lovely welcome from Paul Coyer, and then we will be looking at various things during the morning. An interview with James Moore, who's a patron of Ataxia UK and is one of the actors from Emmerdale Farm. Derek Wood, who I can see is on this call, is doing And It Works for Me, the importance and role of branches and support groups and volunteering within the ataxia community. We've got the new Chief Executive of Genetic Alliance UK, who's taking his first foray out of the office and first time speaking as Chief Executive of Genetic Alliance UK. And I've seen Tony Kay on this. Oh, I have seen Deanna Kay on this call as well. And she is also doing It Works for Me. And then Wendy Oman during the morning will be describing our services and the things that you can get support from us. And then in the afternoon, we will have Jessica Pezza doing And It Works for Me all the way from Albania. Dee Smith, who spoke to us last year, is coming back to do And It Works for Me on body positivity. Adding to the international nature, Michelle Cunningham will be providing It Works For Me, Coping with Canvas, all the way from Australia. And you will have a session with Dan Beacon, our head of fundraising. After the awards, and of course, I'm not going to tell you right now who gets an award tomorrow, but after the awards, we will focus on Ben Spencer, who gave us a conversation last year about his trek around all of the London tube stations in advance of landing in his wheelchair. So he did that while he was still on his feet, and he's going to come back and tell us in an interview with Paul Coyer what he's been up to this year. So for the meanwhile, we bid goodbye to the FAers who are going into the Chance to Connect session. And we say hello to everybody who is joining us for the session on cerebellar ataxia. So if you've just joined us, welcome. This is the first day of our virtual conference this year. We are focusing this afternoon on research and the medical questions that you want to ask the doctors in the Q&A. And Professor Paola Giunti and Dr. Rajiv De Silva are joining us from the London Ataxia Centre. So a very quick refresher on the housekeeping for those who are new to Zoom. Your participant controls are usually at the top or bottom of your screen. You can mute or unmute your microphone on the far left of your screen, but please keep it muted during the main conference sessions and the workshops unless you're asked to speak. You can turn your camera on and off using stop-start video. Do turn off your video if you don't want to be seen. We are recording these sessions this afternoon, but the only ones that we're going to put out are the research presentations from Julie Greenfield. We are transcribing the doctor's Q&A for future use. You can also react to things that are said through the reactions button. And the reactions button is also the place where you go to put your hand up, raise hand. So if you press on reactions, you can then see the raise hand button. Excuse me. The chat can be used to send messages and questions to the room or specifically to Anastasia about technical issues. Say hello, Anastasia.
Hiya.
Oh yes, and loads of feedback because you've got two computers going. If you've got any technical issues or questions about the conference, please either put them in the chat or you can email us at conference@ataxia.org.uk. And we will do our very best to sort you out. Please also check that your Zoom shows your real name with your first name and last name, not something that we can't decipher like iPhone 7, because we need to know who you are so that we can put you into a breakout room later. To change your Zoom name, right-click on the three little dots next to your name and select rename, and you can then put your first and last name in. So with that out of the way, here's what's happening for the remainder of the afternoon. So now we are going to have Julie's research update, and then at 2:50 we will go into the Q&A with Professor Giunti and Dr. De Silva, and then at 3:25 you will get your turn to go into Chance to Connect sessions. So welcome to Dr. Julie Greenfield, who will give us the research update for cerebellar ataxia.
Thank you, Sue.
Share my screen. I'm going to try again with the slideshow and see if it works. Hello, everyone. So this is the cerebellar ataxia research update. So if some of you have stayed here for the FA1, the first slides are going to be the same, so apologies for that. So okay, that's not going to work. Sorry, I will start again and not do it as a slideshow. So it doesn't seem to want to work today. Okay, lovely. So to go over the overview of what I'll be talking about today, I will start off telling you a little bit about the Ataxia UK's research activities and the work that, in particular, the research department does for Ataxia UK. There are 4 of us in the research department. I'll then move on to talk about the developments in the diagnosis of the different types of ataxias, then move on to developments in finding treatments, and lastly talk about clinical trials and taking part in research. So in terms of the Ataxia UK's research activities, since the charity first started, funding research has always been one of the priorities. So we have a funding programme and we are open to research applications from researchers around the world and in fact fund research quite internationally. And we monitor the research that we fund. And each year we do an impact report assessing how the research we funded has done. And we measure the number of publications that have come out of the research or engagement activities, so a number of different measures of the success of research. And one of the things we measure in particular is the funding. So for every £1 that Ataxia UK spent on research projects, it raised a further £5 in further funding for ataxia research. And what that means is that researchers we're funding are being successful in getting further funding after our projects end, and in particular that they are carrying on working on ataxia, which of course is very important to us. Another big part of the work that we do is we organise research events. And in particular, the main event we do are international congresses for ataxia research. We've been partnering with other organisations in the last few years with the 2 US charities, FARA and NAF. And in this latest iteration, also with Ataxia Global Initiative. And we run these conferences. The last one was in 2022 in the States, and the next one is actually this November in London. So we are super busy with the organisation of that event, and we're really excited because it looks like there is a lot of interest in attending, and we're thinking it's going to be the biggest ever event for ataxia researchers that has taken place. On a smaller scale, last year we organised an event for UK-based researchers. So we had about 50 researchers attend that. And we really wanted it to be a smaller event for encouraging networking opportunities and collaboration in research projects. Another part of the work we do is that we provide a link between researchers and the ataxia community, so people affected by the different ataxias. So we can provide assistance in recruitment of people to study. So we always publicise the opportunity to take part in different studies via our magazine, website and e-news, etc. We believe that it's really important to involve people with ataxia in research. So having the patient voice heard in a number of different research projects is really important. And we can facilitate that either through inviting people affected by ataxia to take part in things or by sort of providing the patient voice ourselves, because we've spoken to so many people with ataxia and understand, having done many surveys, understand some of their needs. We work with pharmaceutical and biotech companies. So primarily for a start, if they're new to the field, we would encourage involvement in ataxia research and explain the research landscape and the resources available for research to progress. We also provide assistance within the drug development programs at different stages, introducing to experts in the field, collecting useful information. And I've put here an example of a study where we collaborated with a company, Biohaven, in collecting data on understanding the impact of ataxia in a group of ataxia, SCAR 1, 2, 3, and 6. And we did this via a survey, and then the research was published. So we're really happy to be involved at all the stages in the design of the survey, in getting the feedback from all of you people, participants, and also in analysing the data and presenting it and publishing it. So lots of different aspects of research activities that we do. And really what we see ourselves as facilitators to try and drive research forwards and in the best way we can. So moving on to developments in diagnosis of ataxia. Now we know that there are lots of different types of ataxia with different causes. And I'll be talking a little bit about some new genes that have been found that cause ataxia, talk about developments in diagnosing non-inherited ataxias, and also the fact that there is now whole genome sequencing available on the NHS. So as I said, we know that there's lots of different types of ataxias with different causes. Many of them are inherited. So there's lots of people who have ataxia in the family, different family members have ataxia. And I just wanted to highlight that in just the last few years, new forms of ataxia have been identified. So for example, in 2019, there was the discovery of the genetic cause of a condition called canvas, due to the mutation in this RFC1 gene. Then in 2022, there was a new discovery of a new genetic ataxia called SCAR49. Again, in 2022, an ataxia called SCAR27B. And this SCAR27B is a late onset ataxia, which can start with episodes of ataxia symptoms. And indeed, there was a small study showing promise for a treatment called for AP, and more research is ongoing that to try and see whether that is a treatment that is of value to people with that condition. So what is really important is that even just as you can see in the last few years, new conditions have been found. So if you do not have a specific ataxia diagnosis, it is important to speak to your neurologist or visit a specialist ataxia centres, because some of these more recent ataxias may not have been tested for if you haven't been to see a neurologist recently, for example. And these causes are these RFC1 mutations that cause canvas and SCAR27B are actually been thought to be quite common causes of late onset ataxia. So although many of the more recently discovered ataxias may be quite rare, these two actually may be more common. So really important in terms of trying to get diagnoses. Then talking a little bit more about developments in non-inherited ataxias. So some people do not have necessarily an ataxia that's caused by mutation in a gene. And one example is gluten ataxia, which is thought to be treatable with a gluten-free diet. And another example is primary autoimmune cerebellar ataxia, shortened to PACA. And this is caused by the body launching an unnecessary immune reaction against the cerebellum in the brain. And sometimes the trigger of this immune response is known. So for example, if it's gluten ataxia, but sometimes it's not known, and then it's called PACA. So as you can see in this diagram, there's a trigger, leads to immune response, damage to the cerebellum, leading to ataxia. So a little bit more about this primary autoimmune cerebellar ataxia. How can neurologists diagnose this? There isn't a definitive test for it. Professor Hadjivassiliou at the Sheffield Ataxia Centre has expertise in this form of ataxia, and he has published a paper describing a comprehensive list of clues to help neurologists should they consider whether people might have PACA. So there's a specific criteria need to be fulfilled, and an experienced neurologist or ataxia specialist as if they've ruled out other diagnoses. And one of the important things of primary autoimmune cerebellar ataxia, it's a potentially treatable form of ataxia. So the team in Sheffield did a trial with 22 participants, people with this condition, trying the immunosuppressive drug mycophenolate. And this reduces the immune response that causes the ataxia. And their results using brain scans and ataxia rating scales showed that those receiving the treatment improved or stabilized compared to those who did not, who progressively got worse. So it's another thing that's important to consider if you have ataxia of unknown cause, whether this could be the cause of your ataxia. So moving on from diagnosis, so as I said, there's been a lot of developments in diagnosis in recent years. I now want to talk a little bit about clinical research and developments in treatments for the ataxias. And I'm going to start off by explaining a little bit about the process of clinical trials. So importantly, the first steps are for researchers to have a hypothesis, to know, to sort of think about a type of drug that could work for a type of ataxia. And you get to that by understanding the details of the specific type of ataxia and what causes it, what gene causes it, what happens in cells. You then, if you have an idea of potential drug that could help, you then test it in cell or animal models. And these could be mouse models, for example, or they could be cell models. And in cells, there's been a lot of advances, for example, in developing neurons, nerve cells within the lab. So you can get cells from people's skin samples, and in the lab, you can reprogram them to nerve cells. So then you've got a really good model in the lab that you can test drugs. The next step is, if you've managed to find out a drug that looks promising in these preclinical studies, you then want to make sure that you find out what dose is safe in animal studies before you move on to human studies. So phase 1 studies are normally done either in people with ataxia or in people who do not have the condition at all. And you're really looking at the safety of the drug, how the body processes the drug, and information on what dose is needed and can be used. To move on to the next stage was a phase 2, which would be a larger number of people. And here you're looking at the potential risks and benefits, and also more about, does the drug actually work in people with ataxia, and more safety studies at each stage. And then lastly, you have the phase 3 studies, where you're looking normally at the benefit of the drug compared to no treatment. So this is where you will have placebo-controlled trials. And once again, you carry on looking at the safety. For the rare diseases, you can sometimes combine these phases so that the timescale can be shortened, and that does sometimes happen. And this is very much a sort of rough schematic idea of how trials can take place, but there are exceptions that are not always done in that way. Now, once you've done the clinical trials, the next steps, which are also important, are getting the drug through the regulatory stages. So step 1 is that treatment needs to get a license from a regulatory agency before it can be made available to people with the condition. Now, in the UK, the regulatory agency is called the MHRA, Medicines and Healthcare Research Agency, and in Europe, it's the EMA, and in the US, the FDA. So once you've got your license, or sort of at similar time, in fact, this next step is in the UK, that different bodies need to decide whether the NHS will then provide the treatment to patients. So first you get the license, and then you need to see whether it will actually be reimbursed, whether you can actually have it on the NHS. And the regulatory bodies in England, Wales and Northern Ireland is called NICE, the National Institute for Clinical Excellence, and in Scotland it's called the SMC. And these are important steps that we're now learning a lot more at Ataxia UK due to the developments in Friedreich's ataxia, where we've got the first drug approved. We're starting to work with NICE and with these different agencies to help with the process, because patient groups such as ourselves can have an important role to play in helping the drug approval process, in addition, of course, to the companies who are developing the drug. Now, I wanted to sort of talk a little bit about some of the initiatives and work that's going on in the ataxia area in terms of clinical research and developments. Now, the Ataxia Global Initiative is something I wanted to mention because it's a network of ataxia specialists worldwide that was set up a few years ago with the goal to facilitate clinical development of therapies for the ataxias. So it includes researchers, pharmaceutical company representatives, clinicians, and patient groups. And Ataxia UK, I have a role on the executive committee of this initiative. And many different sort of activities have happened as part of this. One is to get consensus on standardized data and sample collection that can help in trials. And there have been a number of publications that have come out where groups of people have worked in working groups to come up with these standardized data collection advice. There are also this coordination of joint research projects globally, and this is really important in particular for the rarer conditions where you really have a network of researchers who can help accumulate different groups of participants for a particular ataxia, for example. There's an educational and training role, and also one of the aims is to create a database of global trial sites, so sites that can be involved in clinical trials around the world. So I just wanted to mention the fact that this initiative was going on. Another thing I wanted to mention was the importance of understanding the symptoms and the progression of the ataxia, and how important it is for trials and for developing treatments. These are called natural history studies. And here's the list of all the natural history studies that are ongoing in the ataxias, which involve a large number of different groups around the world. So you may have heard the ESME, which is a SCAR3 natural history study in Europe, where there's the London Ataxia Centre is one of the sites that collects information from people with SCAR3. And many of these natural history studies involve participants attending a site on an annual basis and having ataxia rating scales done, maybe blood samples taken, maybe MRIs taken. So a number of different clinical features studied throughout the time, so that you get an understanding of how the ataxia progresses over time. And once you know how it progresses, you can see if you add a treatment in, if there's a difference. And this information has been very useful in recent years for the progression of the development of drugs. And here's a list of other projects that are collecting people with different types of ataxias in the world. Now I wanted to talk a little bit about treatments, and specifically looking at inherited ataxias with genetic-based therapies. Now there's lots of different types of genetic-based therapies. There's gene therapy, for example, where you actually replace the gene that's mutated with a new gene that's not mutated, that's not changed. There's gene editing, where, as the word implies, you're editing, you're making specific small changes in the gene. And there's things called antisense oligonucleotides, where you're taking a small piece of DNA and you're targeting it to the gene and making the gene not read particular parts of the gene to result in changes in what happens once you've read the gene and becomes protein. So to give you a little bit more of an example here, explain a little bit more about these treatments. So for example, in some of the scars, you have a normal gene that would normally produce a protein, and you don't have a mutation, you get normal gene, no disease. However, in these types of scars, you get an increase in the length of the gene, and these are called CAG repeats. So part of the gene that gets abnormally expanded, and then having this mutation leads to a disease-causing protein, and this protein has toxic effect. And the idea is to stop the production of this toxic protein. And there have been a number of approaches, such as these antisense oligonucleotides, that have shown in animal and cell models that this approach can help in stopping the production of these toxic proteins and potentially leading to improvements in the ataxias. Now, I wanted to talk specifically about a ASO treatment strategy in a very rare condition, a very rare ataxia called DRPLA. Ataxia UK has been working with the not-for-profit organisation Cure DRPLA over the last 4 years in trying to develop treatments for DRPLA. And specifically, one of the programmes that's been very successful is this ASO treatment strategy, where, as I explained earlier, where you target the gene and stop the production of toxic proteins, which will hopefully reverse or slow down the progression of DRPLA. And having developed these ASOs, these sort of drugs that can be used in ASA, and testing them in cell and animal models, they showed some promising results. And we actually launched an N-of-1 trial in one patient with GRPLA in the States earlier this year. And it's really quite encouraging to see that in only 4 years, the research started from not that much available to having many resources to do research, such as cell and animal models, having a natural history study, and also having developed an ASO that is trialed in a patient. And we're hoping that this can be expanded to more participants. But it just shows how sometimes research can happen at a faster speed, and it's really quite exciting. ASOs have seen a lot of interest. So another development program I wanted to talk to you that's really important is by the company Vico Therapeutics. Now they have an ASO that targets the expanded CAG repeats. And because the expanded CAG repeats are changes that happen in genes in a number of scars, it has the potential to work in a number of scars. And this ASO targets these repeats, stopping the production of the toxic proteins. And having done the preclinical studies, the important thing is that the company has now started this phase 1/2A trial in SCAR 1 and 3 in 2023. This was started in European sites, and we're hoping for the London Ataxia Centre is currently recruiting participants for this trial too. So it's really exciting to get to the point of trials where you're actually using genetic modifications of the genes. Now, moving back to some of the preclinical approaches that are being studied, I just wanted to highlight a couple of projects that Ataxia UK is funding. These are preclinical projects, so they're not human trials. One project is testing a type of gene therapy called SMART, which, if successful, could be tested in other ataxias. This is being tested in SCAR1 at the moment. And another project is targeting small changes to the gene to prevent this mutated SCAR1 gene from producing toxic ataxin 1. So just to give a few examples of more work that's going on at the preclinical stage. Now, apart from sort of using gene manipulation therapies, you can also use other types of drugs. And in particular, you can also do drug repurposing, where you're using a drug that's already been used in another condition in an ataxia. And here are a couple of examples of Ataxia UK funded preclinical studies where this is taking place. So the first one is a project on SCAR3, researchers in Portugal, which are using nanobodies as a potential treatment for SCAR3. And these are small antibodies made in the lab that destroy harmful matter. They target specifically the toxic protein aggregates in SCAR3. They've been tested in animal models, and this is the research that is going on now to see how successful they could be and whether they could be taken further and maybe into the clinic. And we funded this research with other ataxia charities around the world. And the second one is using an antidepressant to treat SCAR3, a different group in Portugal, where they're having encouraging preliminary data comparing effects of 2 drugs. And this is using animal models. So they're just examples of research that's ongoing at this preclinical stage, where hopefully, if they're successful, they'd move on to the clinical stage. Another project I wanted to highlight is one which is specifically looking at drug repurposing, and this is called the Sympathic Consortium, and it's a group of researchers who are developing novel method to accelerate the use of existing drugs currently used for other conditions, as I said, drug repurposing. And the project involves 9 different neurological conditions, and one of them is SCAR3. And because of that, we were invited to take part in it. It's a consortium that received quite a large grant from the EU, and neuroataxia is one of the patient groups representing people with neurological conditions. And Ataxia UK is working on this project on behalf of Euroataxia, Euroataxia being the Federation of Ataxia Charities in Europe. Now, moving on to clinical trials and taking part in research. Now, a really exciting thing that I wanted to mention that literally was just announced 2 days ago was that Biohaven, the company Biohaven, they announced positive top-line results from their troriluzole trial in people with SCAR. Now, they had a phase 3 trial, and the phase 3 trial included people with different spinocerebellar ataxias, SCAR 1, 2, 3, 6, 7, 8, and 10. And what they did in this recent study is they'd had a trial ongoing for a number of years, but what they did is they compared the results of the people who had been on the trial with natural history data using the Ataxia rating scale, which is modified SARA scale. And what they found is that those treated with troriluzole showed a 50 to 70% slowing of disease progression compared to people who are untreated and who are in these natural history studies. So I just wanted to mention how I sort of mentioned earlier about the natural history study and the importance of them. How taking part in natural history studies such as EuroSCAR, for example, some of you may have taken part in that, as the EuroSCAR was a European natural history study with a trial site at the London Ataxia Centre, and that data from that was actually used to show the benefit of treatments in clinical trials. So it's really quite important and exciting. And so what the next steps are is that troriluzole is already being evaluated by the European regulator, EMA, for the treatment of SCAR3 only. And this was based on the previous clinical trial. So in the previous clinical trial, they had shown that SCAR3 was one of the SCARs that had shown most benefit. So that's why they went to the EMA and asked for an evaluation of the drug in SCAR3. And as part of this, in fact, Ataxia submitted a letter to the EMA providing information on the impact of SCAR3, and so Ataxia UK supported in that effort. And then, based on these results that I just mentioned that were released a couple of days ago, Biohaven also plans to submit an application to the FDA by the end of this year for the treatment of all SCAR genotypes with troriluzole. And they will also presumably be providing this information to the EMA. So the idea is that they would hope that the drug could be used for all SCAR genotypes. So we will see what happens with that, but it's exciting to have just received that news a couple of days ago, and hopefully it will lead to approval, but we will see. And then moving on to just another type of research, I just wanted to mention speech therapy projects. So we've been involved with, we've been funding and working with Professor Anya Lowit for a number of years. We funded some project on speech therapy. So speech therapy focused on good voice production and clear articulation can help some people with ataxia improve their speech and confidence in communicating. This is what some of the research that we funded showed. So Clear Speech Together is a peer support model tested in collaboration with us, and they published some it was published as a successful method of providing speech therapy. And Professor Lowit is currently testing other therapies to decide which is the best approach before finalising plans for a larger trial. So this has been a really successful collaboration with Professor Lowit that has led also to the production of a service within Ataxia UK of online support and speech therapy. So that's quite an exciting piece of work as well. And then I just wanted to mention that once again, a couple of days ago, we got the announcement that there was a drug approved by the FDA in the US for Niemann-Pick type C. And this was from a company called IntraBio. And the reason to mention this is that Niemann-Pick type C is a rare neurological disorder that can present with ataxia. And the drug actually showed improvements in ataxia rating scale. And that was what was then shown in the trials. And that's what was then taken as the approval by the FDA. And this drug does have potential in inherited ataxias, so the ongoing trials in ataxia telangiectasia, but also there were some case studies in the spinocerebellar ataxias. And in fact, IntraBio has had an interest in the spinocerebellar ataxias for a while. Indeed, we invited them to come to one of the Ataxia UK conferences, as some of you may have met them or heard them talk, and they applied for orphan drug designation for the spinocerebellar ataxias from regulators a while ago. And that means that the companies will get some preferential treatment for that that drug in a particular condition. So showing that there is an interest in the ataxia. So we will wait and see whether this is a drug that could be of future of benefit to other ataxias as well. So lastly, talking a little bit about opportunities to take part in research. As I mentioned, the natural history studies, there is a number of studies listed here. There's a natural history study for DRPLA, for SCAR3, and a number of other studies that are listed here, which are available on our website. And similarly, I mentioned here some research that is going on at the moment in improving the diagnosis and management of gluten ataxia, which is a collaboration with the Sheffield Ataxia Centre and other UK sites, such as the London Ataxia Centre as well. And Project Euphonia, which aims to record speech samples to help improve voice recognition software. So this is something that's a generic program for a number of different conditions, but ataxia is also included in it. So if you'd like to collaborate in that, do go and find out more information on our website. As I mentioned already, there's the VICO trial that's taking place at the London Ataxia Centre, and another study looking at speech features in people with SVG7, canvas and gluten ataxia. Now, I know I went fast talking about these opportunities to take part, but they're all on our website, so you can definitely go and have a look there, and they're publicised also via our magazine and newsletter as they come out. So thank you very much for listening. I will now be able to open for questions if anybody has any questions. As we did for the Friedreich's ataxia session a few minutes ago, I would also like to introduce Professor Paola Giunti and Dr. Rajiv De Silva and ask them to join me here so that if we get asked any questions, they could be either to me on my research talk or to the neurologists more medical questions that may come up. So as I mentioned, Professor Paola Giunti leads the London Ataxia Centre, and Dr. Rajiv De Silva is a consultant neurologist at the Queen's Hospital in Romford and also works at the London Ataxia Centre as well. So yeah, thank you for listening. I don't know if anybody has got any specific questions that you want to ask on the chat, and then we also had a few questions that were sent in advance. So I can see that the first question is, are all scars inherited?
Okay, so I will take this one. And the spinocerebellar ataxia is basically a definition of a pathological picture. And so many have spinocerebellar ataxias, but the SCA and then the number is specifically related to the neurodegenerative disorders who has spinocerebellar ataxia and have a genetic cause. And the number has been conventionally created by the group of geneticists, and this is based on the gene and the timing of the gene. So this SCA1 was the first ever gene that has been identified being autosomal dominant inherited ataxias. And we are now more than 49, 50. So every single year we have other few genes. And so this list goes on. And this is really a convention, but it stems from a neuropathological, so in anatomically, the system that were involved in the degeneration were mainly spinocerebellar, and this is why it's called in this way.
Thank you. So I can see that we've got some other questions. Is there any work going on into the use of AI to reduce the time of development of therapies and drugs? Yes, I mean, I think I have heard a lot of work going on in AI in research. Interestingly, at the International Congress for Ataxia Research, that, as I mentioned, is taking place in November, there will be a specific workshop on the use of AI in research. It just shows what a topical topic it is and how people are embracing it. So I know that it will be discussed at the conference. I know that it's a topic that is, being explored a lot. I don't know of any specific projects that I can think of in ataxia. I don't know if either of you can, but I'm sure, it will be used essentially.
Yes, so I am aware of one specific project that has been a trial for another group of ultra rare condition called xeroderma pigmentosum, and the study is ongoing, but it's very complex, and like all the new things that are obviously very much in vogue in anything, we need to be obviously cautious. So we need to embrace, but we need to be very, very rigorous in using these tools.
I was just going to add, I think it's, AI and sort of the new computing sort of, it's such a powerful tool. I think it is probably going to impact hugely on our ability to collect this sort of big data. But I think critical in that though is the involvement of you guys in with Ataxia centers, so that we can input that data as you go along. You've already heard examples of how natural history data have influenced the interpretation of the efficacy of new agents that are being trialed outside of their normal role, or new agents indeed, like omaveloxolone. So it's really in Friedreich's ataxia. So it's really important that we have this data collection ongoing. So for example, in Professor Junti's clinic, it's routine when we see patients to do a SIRA score at each of their visits. And it might seem something of a burden to you guys to be put through the assessment, but actually it's really, really valuable and really important as we go along, because I think this is going to really pay dividends over time. I have also, in addition, so there are some assessment tools as well. I noted at a meeting in Edinburgh, the Association of British Neurologists, there's a young researcher showing me a piece of code which is being used in Parkinson's disease. It's wearable devices, like a phone in their pocket, measuring. But then I was thinking, over time, I'm sure we will be able to utilize tools like that for the assessment of ataxia patients as well. So I think the huge opportunities in the future, but critical in that is your involvement, so that we can continue to collect good quality clinical data from you guys.
So if I may, Julie, to make a comment, just spring to mind following Rajit. So the natural history is something that, as you probably know, I have been involved since the beginning of the Ataxia Center in London, and the main aim was always a translational research, and remain translational research the main aim of the Ataxia Center. And since then, we have collected more than 200 people with different scars. And it was very interesting that all of you and all the patient that has been collected with a Euroscar has been, and the data of the Euroscar in a very anonymized way, has been really, really helpful. All this data collected throughout the years to make the comparator of the clinical trial for the triluzole. So this is something that we are very proud in the UK, you know, through our work, through your really generosity to go through the protocol. And bear with me, the UK has been really a major font of data in the Euroscat. So we have been the largest site, and so the largest contributor of data in Euroscat. So thank you, thank you. This is a great opportunity for me to say thank you for the Friedreich ataxia patients who has as well contributed in the EFACTS, and we are the largest site in Europe. And thank you for all the patients with spinocerebellar ataxia that has contributed for the Euroscat. And we want to continue, and the results with a trial of omavoxalone and with the trial of the triluzole indicated the really relevance of the natural history.
Yeah, thank you. Absolutely. Yes, it's a very good opportunity to remember to thank
Yeah, and to
participants as
say
well.
thank
You're
you
quite
to
right.
everyone who is listening to me, because we have been really helpful in setting up these trials. So yeah.
Yeah. Thank you. That's lovely. So the next question is, you mentioned SCAR27B can start with ataxia symptoms. What type of symptoms? So that's the type of ataxia that's kind of comes up with episodes, like episodic ataxia, the SCAR27B. Do you want to comment further on that? So it's kind of starts as episodes, doesn't it? A bit like episodic ataxia.
Not necessarily.
No, it can do.
Yeah, it can do, and it's like the all the episodic ataxias, or like the SCA6, for example, that sometimes can start with the episode quite a few years before the establishment of the progressive ataxias. But the characteristic of the SCA27B is really late onset, so it like SCA6, it's very late onset after the 50 years of age. And one characteristic is that it's extremely slowly progressive. And also one thing to remember that affects the speech very little, and it's a rather pure cerebellar ataxia. So we usually don't have complication like in other spinocerebellar ataxia, in which we have muscle wasting or very much difficulties in swallowing or speech, as I said, and so forth. So it remains rather an imbalance and less complicated.
And just to add, I think a further feature which may sometimes hint at it, ataxia patients are generally, as you know, more sensitive to the effects of alcohol, but there seems to be a particular sensitivity in SCAR27B as well. So that can be another. So when, but you're right, Julia. At the very earliest features, it may be an episodic phenomenon, and it just gives us it's the combination of things. But I think, generally speaking, Paula, it tends to be slightly older than the EA2, which is the classic episodic ataxia population, isn't it?
No, this is what I'm saying. Is very similar of the SCA6.
Yeah.
Rather than, so the EA2 can be as early as 2 years of age, 3 years of age. So very early. It can be very dramatic as a manifestation, but there are obviously patients in which even with the EA2 are late onset. But in general, there are much more wider age at onset compared to the SCA27B. I'm very sorry, but I need to go because as you could see, I'm in clinic, and but I try to come back as quick as possible. So apologies.
Okay, thank you. So we've got another question here, and then I think we should go to some of the questions that were sent in advance as well. So this question says, I'm in Scotland and diagnosed almost 3 years ago. The support and particularly the access to specialists is so very poor, e.g. I'm 15 months into the process of a cross-border dissolved NHS referral and can't even find out when my case will even be heard by the NHST side. Of course, it may be even rejected, so bad. Anyway, so 2 questions. So that's the sort of explaining the situation. Due to the above, I don't have a SCAR number, which most of the research is aimed at. Would the Biohaven or any other research be applied to this? So that's the first one, about not having a specific SCAR diagnosis, but having more generic diagnosis. If I just start off, so with the Biohaven data, I think what they're hoping for is to apply for a license for all SCARs. But we don't know whether that will be given or whether they'll be given one, say, for example, only the ones that were in the trial. So it's kind of quite difficult to know at this point whether it would be feasible to have it or not. I mean, I suppose one thing would be to see the rationale of the drug and see whether it would be of benefit potentially to all cerebellar ataxias, but I suppose we don't know that at this point. Rajith, I don't know if you want to comment on that.
I think it's a tricky one, and I think there's also some sort of, I suppose, questions that inevitably arise because of this heterogeneous nature of the population that's been studied. We know that not all SCAR, well, obviously the genetic basis of the SCARs are very different, the 49, 50 of them that we have. But additionally, we know that if you drill down, we know that the patterns of involvement of the cerebellum, we talked in the earlier session about how the cerebellum is primarily affected, but there are other parts of the central nervous system that can be affected as well. So the part in front of it, which we call the brain stem, can sometimes be affected and we know that there are distinct patterns depending on whether you've got SCAR1, SCAR2, SCAR3, SCAR6, and so on. And in fact, the upper part of the spinal cord even can be involved in some forms of SCAR. So that in itself raises the question as to whether the biology, the pathology accompanying these disorders is different, and if so, how can a drug sort of work across the board? But again, we were having a rather similar discussion along in the Friedrich story. It just depends at what level. I suppose if there's some form of agent that generally protects against cell death, it could be extrapolated to cover all of these agents. But then the sort of the downside to that argument would be to say, well, in which case the effect must be relatively small. It's not a targeted treatment going to the core of the problem. So you would anticipate that there is the effect. So it's a little bit of a tricky one, and I think it's going to be quite an interesting question as to whether the FDA gives this drug approval on those grounds. Does that help, Julia?
Yeah, I think, yes, it's sort of, it's difficult to tell at this stage, isn't it? But it could be something that could apply to more ataxias if it's a more generic drug, as I think this one is. It's obviously not as specific as the gene therapy kind of drugs and things like that.
Sorry, I lost my line of thought. The other issue, though, is one of the dangers of doing it in such a wide group is that there may be effects on certain types which are being cancelled out by the lack of efficacy in other types. So, for example, the drug that was used before riluzole was a drug called riluzole, which is actually widely available. Even now, it's prescribable here for patients with motor neuron disease. There was an initial trial done across the broad range of subjects, which seemed to suggest that it had some benefit. But then when a group of scientists in France looked at SCAR2 in particular, there was no effect. So it may be that negative effect has sometimes, in some way diluted. So really what we need are cohorts of individual types. And of course, the problem then is that you have such small numbers. which goes back to that original point we made, which is so vital that you guys remain involved in because we will need cohorts of populations, ideally within the individual SCAR groups, so that we can trial the effects of these drugs. It may be very different depending on which type of SCAR that you have. Sorry.
Thank you. And then the next question from the same person is, what are the doctor's views on stem cell treatments? Is this the same as gene therapy? So it's not the same as gene therapy. Do you want to sort of say your views on stem cell therapy?
Julie, you probably know a lot more about the science, but in broad terms, the argument, and I think you referred to it in your earlier talk about pluripotential stem cells. So these are potentially cells derived from bone marrow, for example, which have the potential to develop into nerve cells. But here, and as you may know, even within your brain, the architecture in terms of the cellular structure in different parts of the brain is very different. I'm fascinated. My interest in cerebellar ataxia was triggered by looking at the histology. Just the architecture of the cerebellum is fascinating. It's just a beautiful, beautiful organ. So then, but the starting point is to use these pluripotential stem cells and try and develop them into cerebellar Purkinje cells, etc., etc. The problem, though, is how do you get from A to B, and what kind of stimuli do you apply to make the cells? And then there's the issue about how do you get it to the right place and make sure that the cell gets into the cerebellum and repopulates it. And then thirdly, how do you make sure that the new cells don't get rejected? So these are incredible challenges. I mean, these are amazingly difficult. So this is why, as clinicians, Julie and others as scientists, we take a bit of a step back when people say, oh, well, I'm going to have a stem cell treatment, because it sounds, on paper it sounds, but actually the science and the technology required to get there is incredibly, incredibly complex. And because of this promise, and unfortunately because patients are going through such a dreadful experience, it's a very vulnerable population as well. So it's no surprise, therefore, that there are people, rather unscrupulous people in different parts all over the world, actually, who would exploit that need and say, look, we are offering some treatment. So people travel sometimes long distances, expend a lot of money for something of no proven benefit, and may in fact even be harmful because of sometimes quite serious immunosuppressive regimens are given as part of the treatment. So there's a huge, I think it's an area potentially of huge promise, but I hope Julie will expand more perhaps on the actual science behind it, but it's a really challenging, and we are nowhere near in terms of sort of unscrambling and trying to understand. Don't get me wrong, we would be very keen to take part in well-conducted clinical trials and so on if this were to be a tool. And we know, for example, there have been studies done in Sheffield in the field of MS with stem cells, which are showing some promise. But I think we need more time, unfortunately, and more involvement in greater, more clinical data from trials before we accept it as an intervention.
Yeah. And I think in terms of the field in general in ataxia, there haven't really been any trials testing stem cell therapy transplantation in the ataxias. So it's kind of quite a bit behind some of these other treatments that have reached the clinical trial stage in people with different ataxias. So it's kind of, the research is not quite there yet, as you said, in terms of a treatment. And the clinics that provide stem cell treatment has sort of not been verified, and it's not something that we would recommend people go and do at the moment. So I'm just wary that there were some questions that people sent in advance. So we had a question So one person who had a neurological appointment a year ago lives in Northern Ireland, and she said she was told at the meeting that she was told very bluntly by the neurologist consultant that if it's genetic, they were doing genetics tests, but there was no cure. There's nothing I can do or anyone else. The consultant then wrote to the GP with a detailed list of symptoms, but the person was never told. So a series of situations which weren't very good for this individual. I only found out at a recent asthma review and needed something for my travel insurance. For the past year, without a diagnosis, I've dealt with the illness on my own. So she she said she was going to contact the GP, but they've been overseas, and they just wanted to know whether there was any advice. So I suppose it's sort of trying to get advice from a neurologist to try and get a diagnosis is the issue, isn't it? Yeah. Don't know if there's anything more we can say here. It's a shame when the NHS doesn't work and when people don't get referrals. We do get that. We hear that on the helpline that sometimes people have difficulties in getting referrals. I suppose we always suggest also trying to attend ataxia centres. Don't know if there's anything more to be said that you can advise there, Rajiv.
No, Julia, I think I sympathize with both parties. Actually, I'm obviously very, very sorry to hear about your experiences, but also I think the health service is very, very stretched generally, and there can be particular tension points. But I think all one can hope is that over time things will improve. But involvement in ataxia centers is generally a good thing, or seeing someone with an interest, because obviously that enhances your opportunities of receiving the best available clinical trial. You know, I think encouraging people, not just the neurologist concerned, but also perhaps the general practitioner, and even the therapy teams that might be coming over to your places, the occupational therapy, physiotherapists, and so on. And Ataxia UK, one of the most important tools they have is this thing called guidelines for professionals. And Sue, who was involved in helping us to produce, came up with this title, Towards Best Care. So we accept that it's never perfect, but it is we are striving towards enabling professionals to deliver the best care to you guys and your families. So I would strongly encourage, and it's so kind of a good calling card. It's available on the internet. You can just give them the link, and it's a very good means of introducing them and say, without being challenging, saying, do you mind just having a look at this, because it'll show you what's even in this day and age, what is possible. We're not talking about things 50 or 100 years from now. We can still make things better for in ataxia by using, and these are sometimes quite straightforward things like providing the appropriate support in terms of the aids to get around, making sure that you have your, very, very, and your speech and swallowing attended to, and so on and so forth. No complex things, but it also covers the whole breadth in terms of the what is available in terms of clinical aid, and also some of the symptomatic treatments that are available. So that's a very useful thing to proffer these people if you feel that they're, and frequently these kinds of brush offs and reactions is actually not because obviously they're not being cruel or hard. It's sometimes it's a sort of a way of showing their lack of knowledge and feeling that they're out of their comfort zone and not understanding what's going on. And doctors always, just a personal reflection, they always want to help their patients, and when they feel they're in a position where they can't, they feel very and sometimes these behaviors are a reflection of that. So breaking down that barrier and say, doctor, don't feel like that. There's something that might actually help you to help me in turn.
Yeah, thank you. Just to sort of finish on the questions that people sent in advance, a few people asked about troriluzole and about the VICO trial, so we've kind of covered those, but there was a question about the drug SLS-005, and that is a drug by a company called Celos Therapeutics, which is Trelos, and that was stopped in 2023. But the reason given by the company was actually that because of financial considerations. So it wasn't to do with the safety of the drug, but financial situations of the company. So unfortunately, that program has stopped. And the other program that somebody was asking about was the BIB 132, and that is an antisense oligonucleotide, an ASO study that had started in SCAR3, and it's the company Biogen who was doing it. And that one, unfortunately, was terminated due to results from non-clinical safety data, is what they said. So I'm imagining sort of from animal model data that showed that there was some safety concerns, and that's why that trial was terminated. Just to sort of let people know there were other things ongoing that we've referred to in the past, but that have now been stopped. I'm wary with time. There's a question here about your experience with many ataxia treatments. What's your thoughts on gene editing? It seems like science fiction. Are you hopeful? I mean, I think gene editing and gene therapy did sound like science fiction, but now we are actually getting trials in the ataxia, so it feels a lot more real now. You know, actual people with ataxia are getting injections or tablets, and sort of it is getting quite real. So the ASOs are the ones that have progressed the most. So as I said, they're a little bit different, but they still target the gene and have the effect of stopping the reading of the particular bit of the gene that leads to the problem further down. So it's kind of a small bit of DNA that targets the piece of DNA that's mutated and leads to it being either stopped it from being produced or changes it. So these ASOs are now treatments that are being trialed in people with ataxia, such as the VICO trial. So I think it's beginning to feel a lot more real now that you're seeing it in trial stage.
Julie, I had a quick look at the program for the forthcoming ICAR meeting. There wasn't a lot about CRISPR-Cas9, are there, in terms of gene editing itself? There weren't many presentations, so perhaps it's taking a bit of a backseat at the moment. But I mean, I entirely echo what you say. I mean, it seemed like science fiction, but actually these are amazing tools. You seem to be able to target genes very, very precisely. And if there are, I mean, I mean, I'm a very I'm not a scientist, just a jobbing clinician, but it seems to me that if you can target these expansions, I mean, it'd seem a very viable thing to attack, isn't it?
Yes, absolutely. I think we probably are running out of time, because I can see that people are coming back from the breakout room, so we may need to close this session. I can see there's a few more questions.
Julie, there's a very basic question which I think a lot of people have, is there a difference between spinocerebellar ataxia and cerebellar ataxia, or is it just how we speak?
It is just semantics. It depends. I think in an earlier question I explained that sometimes in the spinocerebellar ataxias you can get involvement of the spinal cord as well. So the clinical picture sometimes reflects not only the cerebellar damage but the involvement of the spinal cord. So because of that, I think a more inclusive, more sort of accurate terminology is spinocerebellar ataxia, SCA, rather than pure cerebellar ataxia. But in day-to-day terms, when we use the terms, neurologists use it or therapists use it, we're talking about the same thing.
So it's still an umbrella term for a group of different types of ataxias, essentially. So there are some slight differences, but essentially it's an umbrella term. It doesn't give you the specific diagnosis. You need to have like SCAR1 if you want a specific diagnosis, but if you say spinocerebellar ataxia or cerebellar ataxia, it's still an umbrella term.
So it's a bit like one of these there will be a proportion of you guys who have a very specific genetic diagnosis like SCAR1, 3, etc. But then the wider group, there will be a spinocerebellar, a cerebellar ataxia, then a spinocerebellar, and so on. And then, as you heard today, in the beautiful talk that Julie gave, there are even non-hereditary forms like the immune-based and so on. So these are just sort of all in, wider and wider circles, if you like.
Yeah. Lovely. Thank you. So I think we've reached the end of the session. Thank you very much, Rajiv, and obviously thank you to Paola, although she's just left. But thank you both of you. It's been really helpful to get your perspectives on these important questions that everyone has had, both in the CA and the FA session. So thank you. Sue, do you
Right, so yes, I'll take back over, Julie. Thank you very much for your work this afternoon, and to Rajiv De Silva and Paola Giunti. And sorry to those who have asked questions in the chat that we haven't got round to. We will store those and try and answer them at a later date, either directly to you or perhaps at another conference like this, where we have a doctor's Q&A. We will wheel those questions out. So I hope you have found the research updates interesting and the Q&A sessions useful. We're now about to launch a Chance to Connect session for those of you with cerebellar or even spinocerebellar ataxia. But just before we launch those sessions, let's go to the Saturday morning agenda in order to remind you of what's happening tomorrow morning. So at the beginning, you will have a lovely welcome from Paul Coyer, and then I will take over and give you an update on Ataxia UK. After that, there's an interview with James Moore, he of Emmerdale Farm, with Paul Coyer, and then Derek Wood will be presenting in It Works For Me, followed by Wendy Omant explaining what support services we can offer you and how they are developing. Then after a break, we will hear from the new Chief Executive of the Genetic Alliance about the Genetic Alliance's campaigning on behalf of all of us. And then Deanna Kay will talk about coping with her ataxia and other health challenges. And Michelle Cunningham will talk about living with Canvas. And then in the afternoon, we will break into workshops initially, off into groups that you will have pre-chosen, I'm sure. And then we will hear from Dee Smith about body positivity, and Dan Beacon will give a fundraising presentation. And then finally, our awards ceremony, followed by a session with Ben Spencer, who Paul Coyer interviewed last year. He'd been trailing around all of the tube stations in London. He completed that, and we will hear what he's been up to 1 year on. And believe me, it's quite interesting. So then you come to your cerebellar ataxia Chance to Connect session. And if you want to chat to other people with cerebellar ataxia, Anastasia will place you into a small breakout group facilitated by our volunteers. These breakout rooms will be kept open for an hour. And then we very much hope to see you tomorrow morning at 10 o'clock. So I hope you've enjoyed this afternoon. I hope you get some support from people in your chat room when we break you into the chat room breakout. Thank you, everybody.